So here's part 2 of our endocrine lecture. We're going to start with oral diabetic agents. So oral diabetic agents, for the most part, are only used for type 2 diabetes. There are a few that have indications for type 1 diabetes, but you don't usually see those used in that population. You might, as time goes on, with the new GLP-1 agonist and the SGLT2 inhibitors, see the growth in type 1 diabetes as just another mechanism for maybe decreasing the insulin burden for a patient, or possibly trying to get those secondary benefits of medication. A lot of some of the type 2 diabetic oral medications have secondary benefits for cardiovascular benefits. They prevent retinopathy, prevent heart attack, strokes, kidney failure, those kind of things, beyond the basis of just lowering the blood sugar and for treatment of diabetes. So type 2 diabetes is more than just insulin resistance. It's an insufficient production of endogenous insulin. There's a loss of sensitivity to insulin from the tissues, and an impaired response of the beta cells. And so those are targets of our medications. That you can see that one example is a sulfonylurea, can cause an increase in insulin production. The TZDs, or biguanides, increase sensitivity to insulin, and then meglitinides increase the secretion of insulin response by beta cells. You also have excessive production of glucose by the liver, which is what metformin, your biguanide, targets. Impaired GLP-1 activity can causes rapid intestinal glucose dumping. So use DPP-4 inhibitors or GLP-1 agonist to increase GLP-1. So GLP-1 is an enzyme that's activated when a patient eats, and then DPP-4 is the inhibitor or is the enzyme that breaks down GLP-1. So we can either treat impaired GLP-1 activity by giving more GLP-1 to where a patient's normal DPP-4, that inhibition is inconsequential. Or we can inhibit DPP-4 so that the patient's natural GLP-1 can take effect. And we'll talk a little bit more about that when we get to those slides. So sulfonylureas, these are the three you're going to see on the market nowadays: glipizide, glyburide, and glimepiride. They all stimulate insulin release from the beta cells, and they all potentiate effects of antidiuretic hormone. One thing to know about these will cause insulin secretion no matter what. The patient's eaten, whether they haven't eaten, no matter what their blood sugar is, it's going to cause secretion. So you want the patient to make sure they're eating, and you want to watch the patient closely for hypoglycemia. They need to know the symptoms of it. They need to watch any change in medication can increase their risk of hypoglycemia. You also want to watch the use of glyburide in patients with renal dysfunction or patients who are elderly, because it has an active metabolite that can accumulate in patients who have impaired renal function. So elderly and chronic kidney disease patients are not going to be good candidates for glyburide. Sulfonylureas go through enzyme cytochrome P452C9, which is not commonly used, so not a whole lot of drug interactions, and its absorption is 100%. So they're very effective medications. You want to watch for cross sensitivity with a sulfa allergy. Older adults are more sensitive. And the adverse drug reactions, looking at them, hypoglycemia, dermatologic rashes, so anybody who has a sulfa rash, SIADH, syndrome of inappropriate antidiuretic hormone secretion, is possible. It's rare, but it's possible. And you may see some weight gain. Drug interactions, basically the drug interactions are things that may increase or decrease its hypoglycemic effect. Clinical uses, we use the second generation drugs. The first generations aren't even on the market anymore, so you really don't have to worry about those. Um, Individualized dose progression is based on response. Just so you know with the dose, that you get 80% of your response from the medication at 50% of the dose. So we'll take glipizide as an example. Glipizide XL, you may want to get, let's say you're going to give 5 milligrams of XL a day. That's going to give you 80% of your response, whereas if you bumped it up to 10 milligrams, you're going to get a small increase in response, but a much larger increase in risk of adverse reactions. So it may not be beneficial to take it up to the full maximum dose. Here you can see some reasons why you would pick it, why you wouldn't. Basically, the reason people use sulfonylureas nowadays is the cost. I really believe that in the next 10 to 15 years, I think sulfonylureas will kind of fall off the map with their side effects. And if the side effects are a lot worse for this than other drugs. Plus, after about 5 years of therapy, sulfonylureas start to lose their efficacy in patients. And with newer things on the market, once the prices of those drugs that we're going to talk about in a little bit, once they come down, I think they'll begin to really take the place of sulfonylureas. Here's your monitoring. Obviously, hemoglobin A1C every 3 months and while adjusting. Also, fasting blood sugars and postprandial blood sugars as necessary for your patients, specific to your patient. And then a CBC at onset, and then annually unless there are more symptoms, because you want to look for, thrombocytopenia and anemia that are rare but can happen. Biguanides. The one on the market is metformin. Metformin is the gold standard for treatment of type 2 diabetes. It decreases glucose production in the liver, it decreases GI glucose absorption, improves insulin sensitivity, and increases peripheral glucose uptake and utilization. So our liver makes less sugar, we don't absorb as much from the stomach, and what we actually use, we use a lot more efficiently. It does not stimulate insulin release from beta cells, so it does not cause hypoglycemia by itself. Where you're going to see hypoglycemia is with the use of other medications. And it's really the other medication that'll cause the hypoglycemia. So metformin and insulin, which is commonly used, commonly see all these drugs in combination. You may see hypoglycemia if the patient is on insulin and then you start metformin. You're going to have to cut the dose of that insulin because you're going to be using your sugar more efficiently, and the insulin is going to cause a blood sugar drop no matter what. So it's really just it's really only in combination with other drugs that metformin has a risk of hypoglycemia. So one thing to mark here is excretion is by the kidneys. You'll hear that patients, there's no longer a serum creatinine cutoff for metformin. It used to be that, over 1.5 in males and 1.4 in females, you couldn't use metformin. It was contraindicated due to risk of lactic acidosis. But that's no longer true. That risk of lactic acidosis is really based on its predecessor, fenformin, which had a lot of cases related to it in patients who had renal dysfunction. But metformin has a very, very, very low risk of lactic acidosis. So because of that, they've loosened the requirements, and there's a serum creatinine cutoff where they recommend dose changes. So based on their serum creatinine, they may recommend a maximum dose of, instead of 2 grams a day, they may recommend just 1 gram a day, or certain ones based on their serum creatinine. A couple precautions. withhold the drug 48 hours before or after any procedures with radio contrast. You want to watch a patient with watch their vitamin B12. So something that came out a few years ago, and this drug's been used for a couple decades now. A couple years ago, they found that chronic metformin use leads to vitamin B12 deficiency, and it's just a problem with absorption. But and you can give oral B12 or injectable, whichever one, to reverse it. The problem is that vitamin B12 deficiency shows as macrocytic anemia, but it also shows as peripheral neuropathy. And so what got people really thinking was that we know that chronic diabetes, uncontrolled diabetes, leads to peripheral neuropathy. So a lot of people were thinking or were wondering if they were having patients coming in complaining of peripheral neuropathy and then putting them on, say, gabapentin or Lyrica or something for that medication, adjusting their diabetes or adjusting their diabetes medications, when really it was just a vitamin B12 deficiency that was causing that neuropathy, which would have been a much easier problem to fix. So you want to watch that if patients complain with that, or you can monitor their B12 along with their yearly labs as they come in. Pharmacotherapeutics, adverse drug reactions, GI upset. That is the number one thing patients are going to complain of. With metformin, you want to start low and go slow. Very, very slow titration. So don't start more than 500 milligrams a day. Titrate up very slowly over several weeks to 2,000 milligrams a day. That's your target dose for metformin. Regardless of what their blood sugars are, we know that dose of 2 grams a day split to 1 gram twice a day has cardiovascular benefits. It has they call them macrovascular and microvascular benefits. Those macrovascular are preventing strokes, preventing heart attacks. Microvascular are preventing retinopathy, renal dysfunction. Metformin is kind of like the wonder drug of diabetes. So you want to go up and go slowly, and you want to use the extended release version if you can. It's a lot easier on the stomach. And patients will complain about that. You'll have a lot of patients, they'll start on this, and if they have a bad reaction, they're not going to try it again. But there's just too much benefit not to have a patient on metformin. So here's another, talking about that slide. You can do immediate or extended release. Extended release is a lot easier on the stomach, and you want to start them at a very low dose and titrate them up slowly. It says here 500 twice a day. I would even start them at 500 once a day and go up very slowly in 500 milligram increments. Alpha glucosidase inhibitors. These aren't used very often anymore. They are basically, the best way to describe them, they're basically sulfonylureas, but given with a meal. They're like metformin, but given with a meal. They're not monotherapy. They can, if you get hypoglycemia, you have to treat with something that's not sucrose, or not because they inhibit the absorption of glucose. So you have to give a different type of sugar. Just straight sugar is not gonna work. So milk is a good option. They cause a lot of GI upset, which has really limited the use of these, where they really don't use them anymore. It can be a kind of a last line for patients who may need something else, but who absolutely refuse to to do injections. So here are the doses. Patient education: take with the first bite of a meal. You do have to take it 3 times per day, which is another reason why it's not used as often. And remind them they're going to have that GI upset, so tolerate it the best they can. TZDs, these don't really know where they are in therapy. A few years ago, they were I believe the number one prescribed. I think Actos or pioglitazone was the number one prescribed medication in America. Incredibly popular. And then it came out that Avandia or rosiglitazone had an increased risk of cardiovascular events. And pioglitazone had possibly an increased risk of bladder cancer. They are very similar to metformin. They don't cause low blood sugar. They cause a lot of secondary cardiovascular benefits for the most part, but they have these risks that that go along with them. So rosiglitazone has pretty much they've stopped using it for the most part. It was a part of a REMS program where you had to sign in and make sure everybody signed papers saying they knew the risk of it, but that's been taken away. But its use kind of really faded away. Pioglitazone seems to be kind of making a comeback. It looks like that it may have some benefit in pre-diabetes and the prevention of developing diabetes, but not really sure if that's going to kind of take hold. But they are options. You want to limit it in a patient who has a history of bladder cancer, or maybe a family history of bladder cancer. You want to, it's contraindicated in patients with chronic liver disease, with fluid retention, for that because it exacerbates heart failure, which is what Avandia has the warnings for. And you can't use it in children. As you can see here, the adverse drug reactions, really congestive heart failure and bladder cancer are the two big ones. Meglitinides, these are basically mealtime sulfonylureas. So they increase insulin release from beta cells, and it has a very short half-life, less than 2 hours. So they only lower postprandial blood sugars. These were exciting when they came out, but they really have fallen out of favor also. Because one, it's 3 times a day dosing, so people aren't very compliant. Also, people don't like the risk of the hypoglycemia that comes with them, because you have to take them right before you eat, and it seems to be just a little bit more difficult than it's probably worth. For not a great A1C reduction. You're probably talking 0.5 to 0.75%. And most of our patients need a A1C decrease of more than that. Your quality medications will give you an A1C decrease of 1 to 2%, and you'll see that later on in the slide. DPP-4 inhibitors are your gliptins. All the names end in gliptin. There's a few more on the market now. When these slides were made, sitagliptin and saxagliptin were the 2 on the market. These are oral medications. They inhibit that DPP-4 enzyme that we talked about earlier. So by inhibiting DPP-4, you're going to get an increase of GLP-1, which is an enzyme that's released in the GI tract in response to a meal. So the great thing about these are that they don't cause hypoglycemia either, just like metformin, because they only work in response to a meal. I can give somebody all the DPP-4 I want, or all the GLP-1 that I want. It doesn't work until you eat. So that makes it really great, and it can help with pre and postprandial glucose levels, and it can even promote some mild weight loss in obese diabetic patients. And the same can be said for the GLP-1 inhibitors that we'll talk about later. Pretty well tolerated. GI and headache, or GI upset, mild, just nausea and vomiting when you start the medication, and headache are are the only side effects. You do have a risk of pancreatitis with these. It's very rare, but you may want your patients to know that that is a risk with it. And it's used in monotherapy or in combination with other diabetic drugs. You'll see this used a lot with, or you can see them produced in combinations with metformin. Januvia is, I think the combination is Janumet. They all have something. They combine the two names into something in met for metformin. So the limit on those is that a lot of insurances may not pay for that combination, but if they can, and you can use that combination, then that's a great way to decrease pill burden for a patient. Just one less tablet to take. They're well tolerated by the elderly. Your patient may lose weight, but the downside is the cost. They are about $130 a month unless the patient has insurance. I do believe they are covered fairly well by insurance, though. You're going to take it once a day in the morning. Doesn't matter if it's with a meal or not, so that's great. Patients can take it whenever works for them, and it's very well tolerated. So it's a good medication to go with. The other side of that is a GLP-1 agonist. So these are injectable. They're like an insulin pen. You inject them into the abdomen, but you're injecting that GLP-1 enzyme into your body. So it's a GLP-1 agonist. So it's going to hit those receptors. The benefit of this is that it promotes insulin release. Again, just like DPP-4 inhibitors, they don't cause hypoglycemia. They can cause weight loss. It helps you just more efficiently use the food that you're eating. But the benefit of GLP-1 agonist is that patients who have been diabetics for a long time, because of the changes that diabetes cause, they don't produce GLP-1 anymore. So after 5 to 10 years of diabetes, giving a DPP-4 inhibitor isn't going to do much, because even if we inhibit the DPP-4, there's no GLP-1 to act. So we can give these medications later in therapy. So some practice sites are looking at DPP-4 inhibitors early in therapy, and then as they lose their efficacy between that 5 and 10 year range, then they're switching people over to GLP-1 agonists. And patients seem to respond to that because they're getting the chance to go with oral medication first, and then eventually maybe having to go to injectable. Precautions: there is acute pancreatitis noticed, just post-marketing research, so there are case reports of it, but it's very, very, very low incidence. And the most part, the only adverse drug reaction you're going to see is just GI, nausea, vomiting, and diarrhea. They happen the most with your twice-a-day medications, so Victoza happens the most, happens the least with the options on the market now. There are actually once-a-week options of there's a once-a-week option of Byetta and one called Trulicity, which are most patients, when they take those once-a-week ones, they don't even notice any GI upset at all. Some of those 1 week ones, patients will notice like a little nodule that they get, and we want to make sure we tell them not to rub that nodule, because that's actually the drug like sitting under the skin. Because for it to be once a week, you do have to inject a decent amount of fluid in there. So if they notice that, they don't want to rub it and get it to release faster. But it doesn't. The patients I've talked to, doesn't seem to be painful. They just notice a small bump where they injected it. Usually used as add-on therapy. A lot of times combined with metformin. All the time combined with metformin. And sulfonylureas if the patient is on those for maintenance. And this one, like the DPP-4 inhibitors and with metformin, can cause weight loss in the patient. It's not huge. It's a couple kilograms, but if you can get a patient to lose 10% of 10 pounds, even just that will provide some benefit. So it's an add-on benefit with these medications. One thing I want to point out with the GLP-1 agonist and the DPP-4 inhibitors is that there's a growing amount of research showing the cardiovascular benefits and those microvascular and macrovascular benefits of metformin and sulfonylureas, which is why you'll see in a few slides these have moved up in the algorithm to be acceptable choices for monotherapy or for second line choice after metformin. Still for every type 2 diabetic patient, metformin is the drug to start with. But then after that, it's always been, pick any of these drugs. Now we're actually getting recommendations from national groups to pick the DPP-4 inhibitors or GLP-1s or another group we're going to talk about in a minute because of their extra benefits beyond decreasing blood sugar. And with your GLP-1 agonist, you're going to have to have different education depending on which one you're prescribing. It's good to have your patient talk to their pharmacist about administration of these because each pen is just slightly different. Where they want to give it, how often they want to give it, and it might just be easier if they can get one out of the box when they get their prescription, and the pharmacist can kind of walk them through it. So SGLT2 inhibitors, these are new from when your book was printed. These actually block the resorption of glucose by the kidney, increasing glucose excretion directly into the urine. Now, this is kind of backwards from what we used to think of and what we still think for patients who aren't on these, that sugar in the urine is bad because that means that the kidneys are getting damaged by it. Sugar going through the kidneys is usually not great because sugar is a large molecule, and we're going back through the kidney. It leads to kidney damage and long-term kidney disease. Well, these medications actually allow the blood sugar, depending on the blood sugar, they allow sugar to spill into the urine, and then it's not reabsorbed further down in the tubules. So the patient is going to have sugar in their urine, but the amount that's being excreted, it depends on the blood sugar of the patient. So this is another one that doesn't really cause hypoglycemia when given by itself, because if you're at a normal blood sugar, you're not going to have any sugar spilled into your urine. Or excreted into your urine. Sorry, spilled has a bad connotation with this, but excreted into the urine, and you're not going to have to, you're not going to be reabsorbing any. So these are really it's kind of novel medications that have come out in the past, I'd say probably 3 years, and these also are having great results in looking at cardiovascular benefits and macro and microvascular. So these are moving up with the GLP-1 agonists and the DPP-4 inhibitors to being probably second line behind metformin for treatment with type 2 diabetes. So you're going to get a pretty good A1C lowering effect. I think there's a chart later on, and if it's not, it's in your additional notes in Canvas of what the A1C lowering effect is, but it's around 1%, which is pretty good for medication. You can see the dosing down below. Each one is slightly different because it does go through the kidneys. It is dependent on their renal function. So patients who are mildly impaired, you're going to have a reduced dose, and then patients who are severely impaired, you can't use it. But the benefit is we can use it in those patients who are mildly impaired, so we can get a large portion of our patients. Adverse effects are hypotension. Basically, that happens because at the beginning of therapy usually, because wherever sugar goes, water's going to go also. So patients will become a little dehydrated to begin with. So you want them to make sure they're staying hydrated. It works kind of like a diuretic. So tell them to stay hydrated, and to if they feel dizzy, to make sure that they sit down, and that if they stand up quickly, make sure that they sit upright for a few minutes before they stand up. Out of all these other adverse reactions, the one thing that you're going to see the most of is those mycotic infections or urinary tract infections. They just just the normal bacteria and the urinary tract infection is going to be opportunistic. You're putting sugar in the urine, and that's what they eat. So there is a chance for patients to have an increased risk of those infections. Now, most patients who stay well hydrated and have good hygiene, they don't see these. I know talking to a research facility in Greer that they were a part of the trial that got Invokana approved, and they said they didn't see any increase in these infections. So it may also depend on the patient and their hygiene and if they're able to stay well hydrated. But for the most part, they weren't any severe urinary tract infections. It was just an increase in number. And rarely you're going to see pancreatitis and skin reactions. If a patient has any symptom related to these, tell them to contact their doctor immediately. Here's a nice chart that I like where it shows which drugs target what blood sugars. So you can see your fasting glucose. That's where you're targeting, your basal insulins, metformin, and NPH insulin, or your Novolin N or Humulin N. Mixed glycemic effect means it does some of both. Liraglutide or Victoza, that's a GLP-1 agonist. That's a twice-a-day medication. Mixed insulin, SGLT2 inhibitors, sulfonylureas, TZDs, and weekly exenatide, so a weekly Byetta shot. And your postprandial glucose are listed there. It's a large number of them. Now you'll see some drugs you can be in different categories depending on if they're. You can see like the postprandial, it says twice daily exenatide. So that's name brand Byetta. There's a twice a day one, and then they later came out with a weekly version. And then there are more drugs in that category that are coming out that would be in that mixed glycemic effect. Here are some really good slides on the management algorithm for diabetes. I'm going to just go through the highlights. These are from the AACE guidelines. I think the slides are also posted in your additional documents. If not, let me know, because they're really good and really easy to follow. It starts to go through principles of what you want to teach your patients. One, lifestyle modification. Always, always, always push lifestyle modification before we treat with medication. We know that doesn't work a lot of times, so we go to medication. You want to avoid hypoglycemia and weight gain. You want to individualize all glycemic targets, especially A1C like we talked about, based on age, renal dysfunction, fall risk. You want to make it individualized. Optimal A1C, according to this group, is less than 6.5. American Diabetes Association is less than 7, or as close to normal as is safe. So individualize it. You want to pick a therapy choice based on the initial A1C. So if your A1C is above 9, the recommendation is to start with insulin. If it's below that but above the cutoff, then you want to go with an oral medication. Then you want to look at one that treats cardiac, cerebrovascular, and renal disorders. You look at comorbidities. You get to goal as soon as possible, and then the choices that include ease of use and affordability. Some lifestyle therapy you can read over. Care of overweight patients, recommendations you can make. Here's pre-diabetes, the algorithm. You can see that for pre-diabetes, that when you get to a point to treating, you can actually use metformin to treat for pre-diabetes. So as a patient who is a fasting blood sugar of over 100, but they're not quite labeled as or diagnosed as a diabetic yet, they don't meet that number yet, you can actually use metformin as to treat that. There's lifestyle for risk factors for dyslipidemia and treatment guidelines and hypertension. And then here's the slide that I really like. So you can see with a patient, when you would individualize goals, every patient here gets lifestyle therapy. And then from that, you look at your entry A1C. If it's less than 7.5, you go with monotherapy. metformin, a GLP-1 agonist, SGLT2 inhibitors, or DPP-4 inhibitors. You can see, even though those are new, based on all of the additional research that's out, they have been moved up right behind metformin. Metformin should always be your go-to first one if they can tolerate it. If it's above 7.5 but less than 9, you may need dual therapy. So you can do metformin plus one of those in that column. You can see the green bar below it, which one has the most evidence and which one has the best recommendation. So under dual therapy, you'll see metformin plus a GLP-1 agonist. Right behind that, which has a slightly shorter bar, is metformin plus an SGLT2 inhibitor. And you can go down from there. Your patient may need triple therapy if not adequately treated. That's okay. After triple therapy, you're probably going to have to go to insulin, or if the A1C is greater than 9%. You can do insulin and other medications. We see that all the time. But you want to make sure that if you have a patient who is on insulin and you're adding an oral, that you have to cut the insulin dose. And usually we recommend cutting it in half and then slowly titrating it up once the oral dose is stable. That way you don't risk hypoglycemia. It's better to have a few high blood sugars for a couple weeks than to have a low and the patient pass out or have a serious event from it. And then if you have a patient on an oral and you're adding insulin, you just want to increase the insulin very slowly. Start at a low dose and go up slowly. Here's some algorithms for adding insulin. So whether your A1C is less than 8, you may want to do a total daily dose of insulin of 0.1 to 0.2 units per kilogram. If it's over 8%, 0.2 to 0.3. Then you can look down below insulin titration every 2 to 3 days, given those fasting blood sugars or if hypoglycemia, what kind of reduction you should have. On the right side, it talks about prandial control or mealtime insulin. So it gives you guidelines for adjusting insulin that way. At some point, type 2 diabetics at some point in the career, or at some point in their treatment, may reach a point where they have to be on insulin, postprandial and basal. So this is a good slide on how to start that. Usually a general rule is half their insulin is basal and 50% is postprandial, and then you give it based on divided up with each meal. Some profiles just of tolerability of medications, which is a great slide to just keep in hand for treatment of patients. Okay, so moving on to real quickly, we're going to move on to other medications. So glucagon. Glucagon is considered an insulin antidote. So these are for patients who are hypoglycemic or have had an insulin overdose and are non-responsive. If your patient's responsive, use glucose tabs, use a soft drink with sugar in it, use something else, a glucose gel. But if they're unresponsive, you want to give glucagon. So it stimulates hepatic gluconeogenesis and the breakdown of glycogen, raising blood sugar. It raises it within 10 minutes. You still want to send them to the emergency room if they've had this. And you probably want to prescribe all of your patients who are on insulin one of these pens to keep with them, kind of like you would an EpiPen. It's well absorbed. It's extensively metabolized by the liver and kidney. You can use it in pregnant women, and you can use it for and the only adverse reactions are nausea and vomiting. So you can see the clinical uses of it, how to administer it. It's fairly straightforward. It's just a kind of an injection that you give, kind of like an EpiPen. Real quickly, thyroid hormones. I know we've gone on and on about endocrine disorders. Thyroid hormones. So you have three options: levothyroxine, which is T4 or Synthroid; liothyronine, which is T3, which is your active thyroid hormone called Cytomel; or Liotrix, which is a 4-to-1 mixture of T3 and T4. I can tell you right now, barring the most extreme circumstance, Liotrix is a marketing scam. There's no point to it. It's expensive and there's no clinical benefit to it. Your treatment of choice for patients who need thyroid hormone is going to be T4, levothyroxine. It's stable. It gives you steady results, and unless they have some kind of problem converting it, it is converted when necessary to T3, its active component, in the periphery, so when it's needed. So there's a less chance of making your patient hyperthyroid. Here's some more information about those. The only time you really see liothyronine used is I see it sometimes for patients who've had a thyroidectomy who need T4 and T3 in combination, but the synthetic T3 T4 ratio of Liotrix doesn't make any sense, because after 5 days of getting Synthroid, your body is going to convert it to T3 at a 4-to-1 ratio. That's the ratio the thyroid puts out, T3 and T4. It just doesn't make any sense. It's way too expensive and provides no benefit. You'll see that thyroid hormone is a pregnancy category A medication, one of the few. So it can be used during pregnancy. It's just they're going to require an increase of about 50% during pregnancy, because just right off the bat. Adverse drug reactions are just the symptoms of hyperthyroidism if they're getting too much. Drug interactions are basically you want to give it on an empty stomach before you give any other medications, so that you can have proper absorption. Clinical use, TSH levels greater than 10, or symptomatic patients with a TSH greater than 5, and usually it's lifelong. Antithyroid hormones, propyl uracil, methimazole, are used when a patient is hyperthyroid. The difference is propyl uracil can be used in thyroid storm, so it prevents the conversion of T4 to T3 in the periphery. Methimazole only prevents the excretion of thyroid hormone from the thyroid gland. PTU does also, but PTU has that extra benefit. This is a great slide to kind of understand the differences of the treatments for hyperthyroidism, radioactive iodine ablation, surgery, and medications. PTU, you can see here some more information on it, doses and administration. Adverse drug reactions, can be usually well tolerated, but can have some severe reactions for a few patients. Normal monitoring. The differences, PTU is more likely to cause liver dysfunction, but methimazole has been associated with more fetal abnormalities. So that kind of pushes you PTU towards pregnant patients, and methimazole towards patients who may have liver dysfunction. It's more of treatment of thyroid storm. And that's it. So if you have any questions, I know that's a lot of information, a lot more than what we're used to in a lecture. If you have any questions at all, please let me know. Again, we could spend a whole semester talking about just diabetes. So there's a lot more to go into it. Look at your additional documents on Canvas, and if anything comes up, just let me know.